Okay. So, very brief introduction. I'm a physiotherapy. I see men and women. I probably see, well, last time I checked, it was 60% women, 40% men. But I think it might be climbing in the men department. Yeah, so I do enjoy treating men. I find it incredibly, men and women really, but men are really rewarding because they need help. So the first bit is really about the fundamentals of men's bits, pelvic floors, the intricacies, a little bit of how they differ slightly because of their dynamics, I suppose, and touching on the research of why we should be getting them to focus on the front of their pelvic floors and things like that. So look, am I speaking too quickly already? How are we going with the tone?
All good.
Everyone, okay, cool. There is a plethora of evidence, maybe not as much as women. It's a younger area of practice, I'm sure you're aware. But if you want the evidence, I've got a whole big sheet of it, but I thought that would be a big, not a waste of time, but a waste of time about today. But, you know, there's a lot of evidence on all these areas, which is encouraging because we can help in all of these areas. And there is a nice picture. I sort of made a 3D, you know, that app generate. And you can clearly see if my mouse is going to work. My mouse isn't going to work on the screen. No, and that's going to get it forward. So you can see there clearly there are bits of the pelvic floor that go right into the base and a bit further into the penis, and there is parts of the pelvic floor, much like a woman, that are toward the back. So it is this front part around ischiocavernosus and bulbospongiosis and at the front that really have an impact on the closure mechanism, especially with urinary incontinence. Certainly if it's fecal incontinence, we're just wanting to really focus on the back part of the pelvic floor, but a lot of guys are presenting for erectile dysfunction, premature ejaculation, and you know, urinary incontinence, so we really need to be aware of how to light up the front of their pelvic floors. So here's a bit of sort of research on how men tend to be rather dominant in the posterior part of their pelvic floor. And of course, the posterior part is the external anal sphincter and puborectalis, which tend to dominate. And then there is the more anterior striated external urinary sphincter and bulbocavernosus, which tends to lift the testicles and retract the penis in. So I tell men they really should be seeing their bits move when they contract their pelvic floor. And I suppose it's one of the advantages of being a male. There is more to see when the pelvic floor does its thing, I suppose. But all three compress, all three of the pelvic floor actions compress and put a kink in the external urethral sphincter, which leads to urinary continence. So this research on Stafford, you might have seen, just going to you know, flick over it, based on ultrasound examination, and showing that what cues get guys working the front part of their pelvic floor the best. So just for a bit of a landmark anatomy there, this is what we should see. I would use, oh no, so can you see my mouse now?
Yeah.
Yeah, good. Okay, so the bulb of the penis, you can see the urethra coming up through toward the prostate, the angle of the bowel coming down. I suppose what I tell, I'll play this, and what I tell chaps is the first thing to look at, because it's a lot to understand. It's obviously looking transperineally. If you look at that bit there, you can see how much the penis pulls in and relaxes and pulls in. And then I get them to look at the tube of the P-tube and look right there, and you can clearly see a bit of a kink being made in it. If I just play it again. And if they keep their eyes there, they understand, oh yeah, it's kind of like putting a kink in my garden hose when I can't be bothered going back to the tap when my hose nozzle flies off. I'm just going to put a kink in the hose, and then that helps. But also around here, the striated sphincter sphincters up and helps stop the urinary flow. This is a ultrasound of somebody who I think is more dominant in the back part of their pelvic floor, and really you can see much less of this retraction of the penis business going on, and a whole lot more back happening here. So cueing a guy of how to make sure he's moving his bits in the front before lighting up the back would be the take-home message or the goal. So excuse the graphic, but there are some well-researched cues that have been tested of what gets guys lighting up the front of their pelvic floor best. And I give guys a variety, and then they choose what makes sense to them. And because I'm testing them with ultrasound, you can see what worked better and what their brain computed. So now I can't use my mouse again for some reason. But you can see there's a dimple just above where the shaft goes into the body. That will occur. You can retract the penis, lift an erection if there is one. They can do that in their fun home time. If there isn't, you would see some movement of the penis withdrawing into the body slightly. Lifting nuts to guts is another one of Joe Milios's, my good colleague from Perth's, descriptions that works well. I think this cue of Joe Milios's works well, and she's copyrighted it, interestingly enough. Relax the belly and butt, because you obviously wanting them to focus not on muscles which don't help, and what guys typically do. And squeeze the front passage, or try not to pee, and lift the nuts to the guts. But just work with whatever they understand to a degree. So when it comes to the biofeedback trainer, I think it's absolutely gold regarding this research and how it happens to be designed, whether it was purposefully or it just happens to be a really good, convenient design. That the angle of the sensor, I think, is very much up against the front of the pelvic floor. So that's, I want to say, very handy. As far as the MFT, I describe to men where I'm wanting them to feel the stimulus is basically behind their balls, but in front of their back passage, so on the perineum. And I play around with positions so they know what the difference is, I suppose. And we can perhaps talk about what you do to make sure you feel like you've got it in the right place. But I'm certainly not wanting it right back under their glutes and butthole. This is, I played around and even more last night, but I do use ultrasound a bit, not all the time, because again, you can tell a lot from and I think actually the biofeedback trainer is equally visual in a different way, as you understand, but also very, very objective and fantastic as far as comparison between treatments and things. But nevertheless, this is a visual tool. So I don't know whether you use ultrasound. This is just a transabdominal voluntary contraction of the pelvic floor, where we'll see the base of the bladder rise, because the pelvic floor, which is a bowl, and when it's relaxed, it will tighten and lift. And you're probably quite familiar with that, but that is well-studied measure. Trying to see how much, I think really quite difficult to tell how much endurance they have, because the pelvic floor lets go and fatigue slowly.
These are marking on a new roll.
Sorry, was that a question?
Question from?
I think, Nathan, I think it was somebody's audio that.
Okay.
Yeah.
Oh, rock on. Sorry. This is just the same thing happening, but this time the base of the bladder is here. It's a sagittal view, and it's a nice view of seeing the pelvic floor, which is way down here somewhere, off the screen really, pushing the base of the bladder up that way. That's a view. You can get a really nice volume of the bladder to check for post metrician volume. Now, I had a bit of fun. This was just last night, pretty much hot off the press. I thought, what happens if I'm going to risk my my transducer and get on the chair and see what happens to my pelvic floor under stimulus, and it was on 5 Hertz, fairly high level of intensity. Yeah, you can see the rigors that the pelvic floor is going through. And argue surely that is getting a lot of fast twitch fibers, but it'll be good to have a discussion with much more learned people about the physics and muscle anatomy than that. But yeah, aside from the fact that it makes you jerk around, it's a pretty good, clear evidence that the pelvic floor is full. Sorry, I went ahead 2 seconds. So, you know, that muscle is jerking around there and showing evidence of lifting the bladder pretty obviously. This is more of a smooth contraction. I tend to like 35 hertz, but anywhere 30, 35 hertz. You can clearly see the lift action happening as well with stimulus. It's more, oh, sorry, mostly happening there and releasing. So this is just, you know, basics that we remember. It's still convention that 70% of the muscle fibers are endurance, and when it comes to functions, that'll be endurance functions, walking, bladder control, sexual function, fast twitch for coughing, sneezing, sudden need of sudden response from the pelvic floor. We still need a maximal voluntary contraction. This is just with you know, exercise prescription and how we should apply it. So it'd be good to discuss how we should be applying this regarding the chair. Yeah, we need a maximal voluntary contraction, and obviously, I mean, I do a lot of practical application and make sure those exercises are functional and applied to exertions as well. The good thing, there is a load of evidence supporting urinary continence, but also urinary continence after prostatectomy. So it's nice to know there's a basis to what we do. And also, you know, treating and addressing pelvic pain. And, you know, I don't think the MFT is always the answer, but in my experience, applied with a careful trial initially, if you feel it's appropriate, I have found it invaluable. Sometimes it's just as long as you check that there's not, you know, central sensitization situation going on, just with a very, you know, intelligent initial gentle trial. But then if there's a really good response, and there typically and commonly is, it is a very tricky thing to treat sometimes, and it's just a really fantastic adjunct to guys going away feeling like that the pain has reduced and it's headed them in the right direction. There's my understanding of the research is it helps very much normalize tone, and I describe it to a woman and men, that it's really kind of teaching the body what is on and what is off. And if the tone is very low, it tends to bring it up to a more normal level, great for, you know, the tone that is required to control prolapse in women. But in a highly strung person with pelvic pain or, you know, overactive bladder presentations because they have, you know, excess tone in their pelvic floor, I have never really seen somebody head in the wrong way, in the wrong direction, with using pelvic power MFT as an adjunct. Say they're overactive bladder and they have an overactive pelvic floor, and my exercise prescription would be very much down training, using the MFT to help normalize tone, is I find very helpful, and I don't think anyone should be fearful of doing in myself for the results I see. Another study on pelvic pain syndrome. So just to know there's a basis. So onto the one case study that I got, because I thought I'd take up time just talking about that. This chap, he was 72. He had a long history of pelvic pain, which is a very typical presentation of, initially may have been prostatitis, but it was certainly blamed on prostatitis. I think it was probably prostatitis. And then it becomes type 3 prostatitis down the track, where many years down the track, where it's not any evidence of infection, the blood tests are normal, etc. And I'm sure we've seen that before. So this guy was that. So my concern was, try to normalize the tone of his pelvic floor, down training, kind of a pattern. But then he went through because of his prostate's health and the discovery that he needed to have his prostate out, then I treated him as a post-radical prostatectomy. So yeah, 20-year history, many bouts of pain, and initially he was palpably tender on digital rectal examination. He had traces of blood, and it tended to settle with antibiotics. Interesting that the whole antibiotic scenario can kind of act as an anti-inflammatory to some degree as well, which is interesting. He had pain in the pubic area, perineum, anal pain, end of the penis and into his thighs. But he often blamed the onset of winter, but typically, like if you've ever seen stress wind up pelvic pain in men, you're not alone. So when he described it as busy, and busy often means more stressed. So I first saw him in his last bout of pain, and why he went to the urologist and eventually was sent to me. He had another bout of pain, and this time it was going into his right hip as well, and the testes. He was settling it with hot baths, and he was a bit of a cyclist, but he'd stopped that because he was worried that was aggravating things. It was impacting his erectile function because of worry about what was going on, but actually he'd completely backed off from any sexual function because of very painful orgasm. He had no lower urinary tract symptoms, good flow, good initiation of peeing, but he had some discomfort from particularly bowel motions. But as is kind of very common, all his bloods and palpation was normal. So he came to me because the very good specialist, one of the very good specialists that I work with, thought pelvic floor might have gotten in on the game here, which is a lot of the time. So when I saw him, he was 4 out of 10 pain. He rated his problem an 8 out of 10. This might give you an idea of kind of the measures that I use and I find really valuable, and especially when you're justifying your existence or just monitoring your process. Really invaluable, I find, to be able to report validated measures back to specialists when they refer you someone, or when you've got a referral. And it proves what you're doing is working or headed in the right direction, or justifies that you need to move them on, I suppose. Don't ever estimate, in my opinion, asking about and measuring nocturia. Such an easy thing to ask, and we know it should be 0 to 1. But I commonly see, I don't know about you, but I've seen a massive correlation of just that measure nicely reducing. It's kind of like with magnetic field therapy. It's kind of like I describe it as a very useful side effect when people didn't really intend to come in for that issue. I've kept track over the years in a spreadsheet, and I reckon it would be a great thing to study because it would show a really good result. His erectile function, he thought it was around 17. He was not leaking. He had a big abdominal hernia, bit of a tummy on him, and he was a mixed breather. He was recruiting his pelvic floor correctly. There was a very small post-void volume. There was no notable tenderness in his pelvic floor. But I'll show you the BFT. I took photos of the BFT results, and there was perhaps you don't see it so much on the photo that I got, but you can see it in real time. It was a bit of difficulty letting go. And so on day one, of course, I did my usual physio thing and talked about pain and how the sympathetic nervous system influences tone in the pelvic floor, what the pelvic floor does. Obviously, the pelvic floor should have a range of motion. Talked about what is tone and how breathing can be used to influence that. Started pelvic floor down training. I gave him a trial on the chair, and those were the settings I used. Coil position really comes down to body dynamics, how big somebody's bottom is, and how large a man they are, as you know. So I trial moving it around to feel like it's in the right place for them. So just 10 minutes at level 1 because I didn't want to wind them up. And then lockdown happened. Yeah, happy memories. Further, yeah. So, but then basically he, now we'll skip forward to October 2020. Lockdown happened, and basically, I didn't see it on there, but basically he had no aggravation at all from the chair. But he also had no great improvement over lockdown and with his pain situation. And then it was discovered that he really needed his prostate out. I think his PSA increased, and they did a biopsy. And by the time I saw him again, he was told, yeah, let's do this. And it was booked to be out on the 9th of November last year. So I had 4 opportunities to get him using the chair. And I added in a bit of an emphasis of using his pelvic floor with economy, with exertions and the neck, and really just priming him up, getting ready for his surgery. And this is post-op, late last year. He presented then, of course, with a degree of incontinence, having to be 11 out of 21. It turned out to be non-nerve sparing, which of course is another risk factor for further and more significant incontinence issue, and of course erectile dysfunction. So we kept on doing functional pelvic floor work, and this is how I led him through MFT. Initially, I used post-prostatitis. I think that personally, that is a program that I use very more early on after radical prostatectomy. But I've got to admit, I do move towards really working out the pelvic floor a lot with stronger, strong programs, I feel. But I'm very happy to be challenged on my thoughts of doing that. It seemed to work for him, but. So we did full time, and basically on the first session went up to level 3, and just you can see I just gradually increased the level and for how long he was at that level. By the 5th treatment, I moved back to men's hypertonic, which is what I was using initially. I just tend to like that because if there's somebody with a bit of woman or man, I use men's hypertonic with quite a lot of women with an overactive. But I'm happy to be challenged about that logic as well. And by the 9th treatment, he was full energy, level 6, and typically using men's hypertonic. So this is pretty much where he's at now. I'm still seeing him once a week, and once every week to once every 2 weeks, and he's still improving. But he's come a long way. His incontinence score is in the mild range, but I'd really like it to be nothing. He's dry through the night, which is good. He is using a pump because we want to preserve or maintain penis size, so it doesn't retract, etc., and it's easy to pee. He's had no pain, but thankfully. Whether that's because the prostate's gone now, or whether it's because I've sorted out his pelvic floor tone and it's the nervous system's agenda, either way, it's great. He's got no pain. He's still, I delicately ask him occasionally, have you tried Climax yet? And he still hasn't gone there, which is totally fine. But I'd be really interested to know whether it hurt anymore, just because I'm my personality. He's not wearing pads at night, and he's basically wearing 1 pad a day. He does a lot of manual work. So this is another thing that I do. I see people on the BFT every treatment. That's not necessary, but I just think it's quite valuable working just for 5 minutes. It just, I suppose, of course, it would lock in patterns and engagement with their own work and efforts. This, just out of interest, was his top scores for the basic training. And you can see, like on the 10th, he had a really tired day. It'll fluctuate up and down, but it's certainly trending towards higher and better skill ability. His top of 63, which is getting quite good. I think my top is like 76 or something like that. And this is the other thing that I do is I just take a picture of the screen with my phone and I import it into their notes, because I take electronic notes, And this is really good. If I'm referring back to a specialist saying, hey, this is a situation now, this is what his quick flicks look like on day 1, and this is what they're like now. It's kind of like that specialist is going to send me more patients. And they do, because we can objective. It's not my opinion. It's a good solid evidence that somebody has improved, which is really nice. But yeah, that was day 1 in January 20, and you can see it was pretty shaky endurance on the right, and then clearly showing a bit of a sign of ability to quick flick in February. That was partway through the process of getting him really strong after his surgery, of course, reasonably recently. A lot more solid endurance on the sustained hold, and this is in March. It sort of clearly shows he's able to release really well and quickly, and he's got a good amplitude of contraction on quick flicks, and still a very good endurance. So 99.9% of the time, those tests will correlate with continent sort of scenario. So yeah, that would be all I have to say, and hopefully we can have a good discussion. I'll just non-share my screen if I can. Oh, how on earth? Stop share.
Hi. Hey, Nathan,